looking at enteral nutrition. Okay, this is, you could call it a technique, you could call it an intervention. Last time we were looking at a brief introduction to clinical nutrition, where we looked at the nutrition care process. So, and under the nutrition care process, we looked at things to do with the nutrition assessment. We looked at things to do with the nutrition diagnosis, from which you would indicate a nutrition intervention, which would then go on and do a nutrition monitoring or evaluation from. And today we are going to interest ourselves with enteral nutrition. Basically, this is in our clinical settings a technique that is usually used. We realize that under circumstances when people can't eat, or when people can't consume anything orally, when they're having oil challenges, we don't expect the body to just cease functioning. There are other ways in which we can transfer the nutrients that are required for proper functioning of the body to that body system. Okay, so that at the end of the day, not because someone can't chew that they are going to become malnourished, not because someone can't swallow that they are going to become malnourished. Okay, so these are the techniques that have been researched about that can indicate or that can transfer the nutrients into the system, even if some parts are constrained. Okay, so under enteral nutrition, we will expect you to understand the indications. Indication is when is it given, when is it required. Then the contraindications, when not to. For the benefits, we will also look at the benefits and risks to enteral feeding. Also, we expect you to be able to identify the types of enteral feeding tubes, the formulas for preparation of these enteral feeds. Maybe you would also be in position to tell us various enteral feeds at the end of this engagement, and also when required during an assessment. And also you will be able to tell us the different delivery methods that are in there. Also be able to monitor and evaluate a patient's tolerance, complications, and also the outcomes of the enteral feeding, and also be able to provide this education and support to patients and caregivers on enteral feeding. You realize as we go further into the course that these are when we talk of enteral feeding, no one really wants, in most cases, the patients, whenever you tell them we are going to be transmitting feeds into your body, but not through your mouth, through the various parts, someone will feel, remember, it's not a usual thing, it's more of a treatment. Okay, we are trying to bypass the normal system so as to transfer the nutrients into the system in a different way. So in most cases, people here need a lot of sensitization here and there. We will look at that, but really we are looking at finding a way how we can deliver nutrients to a person who cannot consume orally. All the nutrients, the proteins, the fats, the carbohydrates, the vitamins, the minerals, so as to meet the nutritional needs of that individual. Right. Like I told you earlier on in our course that all the information you have right now, all the knowledge you have right now is of importance. From the elementary school where you are looking at the system, the digestive system, the circulatory system, the respiratory system, etc. All these things, science doesn't lose meaning. Okay, it is from the basics, the building blocks that we keep going on and on and on and on, etc. So when we look at that picture, let me try zooming in. Okay, I hope it's fine. And we are saying enteral nutrition involves providing nutrition via the gastrointestinal tract, okay, using a feeding tube. Sorry about that. Okay, using a feeding tube. And the feeding tubes are various in kind. For people who have worked in clinical settings, you realize that when a child comes and they're malnourished, or when a child comes and you enroll them in ITC, and this child there is what we call nearby mouth in most cases. Okay, and the person, the child is not taking in anything by the mouth, or they are getting, they are vomiting everything that they are trying to take in. The F75 you're giving them, they are vomiting everything out. The F100 you're trying, even the rhizome you're giving them, they are trying to vomit it out. So what do you do in this case? There are guidelines on how to feed an infant who is not taking anything in orally. I don't know, someone I think is, yeah, someone's mic is open. Please mute. Thank you. Uh, you realize that now the feeding route is different. We are not taking in anything through the mouth. So what does your science tell you? That there won't be chewing. Okay, first of all, if you're looking at us using the nozzle, the nozzle area to take in the food, first of all, we will need a delivery tube. Okay, so that delivery tube, it will be a nasogastric tube, or we are trying to find where to put those particular nutrients. If we are going to be putting the nutrients into the stomach, then that will be nasogastro, from the nose to the juices. Then if it is from the nose to the duodenum, that will be nasoduodenal. Then if it is to the jejunum, the small intestine, that will be nasojejunal. And we'll have to understand which nutrients are going to be apologies for that. If it is for the nasogastric, it is from the nose to the gastric system to the stomach ideally, and nasoduodenal to the duodenum, and nasojejunal to the small intestine. And we will have to understand which nutrients are absorbed at what part of the digestive system, so as to be able to successfully transmit these nutrients to the body of that individual. You realize that a lot of steps are being missed. For example, in the mouth, we don't expect the crushing of the food using the teeth. Okay, so we don't expect that. So the food that you're going to deliver won't need chewing. So you will chew the food on behalf of that individual. I'm not saying you're going to first chew the food and put it in the tube. No. What we are saying that the type of feed that you're going to be transmitting is not going to require chewing. So the food will be in a form that is not supposed to. That's why I'm giving you an example of the children that require the F75 and F100, that these are not solids. Okay, these are fluids that you're going to be transmitting. Okay, and at a later stage, we will all realize that at one point we have undergone enteral nutrition, and we will see about that. Ideally, that is it. Okay, so you will undermine the role of salivary amylase if, for example, you're bypassing the mouth. We don't expect now the food you're going to give should be already upon and can be easily absorbed. Alright, so under enteral nutrition, we are saying that here the nutrients are directly into the gastrointestinal tract. Okay, and what are the advantages? The advantages are there is preservation of gut integrity, and also stimulation of digestion and absorption, because here ideally we have tried as much as possible to make these nutrients easy to absorb compared to the losses that could come in handy. We are now giving a targeted amount of feed into the body. Okay, there are losses that happen when we chew, then there is that extra, maybe there is that hard core or hard material that now cannot be digested by the body, that we are losing a bit of the nutrients here and there. But now when it comes to this enteral nutrition, we have the required amount of nutrients that we are indicating into the particular point in our gastrointestinal tract. Okay, so and also maintenance of the gut-associated immune function, as you can see. So here I could also tell this to you that when we are indicating enteral nutrition, or when we are prescribing this as an intervention, the clinic, we are not working in isolation. Okay, nutritionists. I don't know how about that side, but some of the practice has been you are not the one to insert the nasogastric tube, tube into the child or an individual. So what happens is you're working in unison or in collaboration with a particular team of physicians or people who are around. The nurses, I think, have the mandate to do this because I've seen things go wrong when people are trying out on this enteral nutrition. That is why we are saying this is a form of treatment. Okay, if a child can still chew, if an individual can still chew, if we can still give these feeds orally, please, we want things to be given orally. Okay, in most cases, what happens is even if there is a nasogastric tube in a client or in a patient, still people try as much as possible to make the oral route active. Okay, so as the person after recovery, still they can go back to the oral route. It is on weird cases or extreme conditions or extreme cases that we will actually set for enteral nutrition, because this is just treatment. We want a person to come back to their normal well-being. That is the core function of the nutrition you're doing at the end of the day. Okay, and I think you could also interest yourselves and go and look up most of these nasogastric tubes, the nasoeccentric tubes, etc. Okay. Indicators or indications for the enteral nutrition. When do we give enteral nutrition? We are looking at severe malnutrition. Okay, and like I told you, there are standards. Okay, so you look up the standards, and if you see that this person falls within that category, then we could also talk of enteral nutrition. Reason because we believe that if we are giving things orally, we may lose a life. Okay, if someone is vomiting and everything we give, this person is having that reflux, they're vomiting almost everything, they're emptying their stomach contents every now and then. What do? We put in an nasogastric tube. So maybe we are trying to bypass whatever is causing that regurgitating of the stomach contents by indicating the nutrients directly into the stomach. Like I told you, the inability to swallow or digest the food, so we are giving them somehow already digested feeds into their digestive system. Also, bowel obstruction or resection. Bowel obstruction is a very common bowel obstruction is a very common issue. Excuse me. And here, in bowel obstruction, we believe that, how can I explain this? So this occurs in most cases when there is a complete blockage in the normal flow of the intestinal contents. Okay, we all understand that our feeds flow by gravity. Okay, yeah, through the intestinal system. But if there is a blockage and then there is no normal flow, this can happen. Okay, it usually happens in the small or in the large intestine, which we call the colon, and this is a serious medical problem. Issues could be due to hernias, whereby tissues are pushing through the weak points in the abdominal wall, and such would be the things that would lead to this abdominal or bowel obstruction. Okay, and we are saying here, people will come to you telling you about things to do with the abdominal pain, distended abdomen, if you're seeing the abdomen is distended, and also the inability to pass gas. Some people feel nauseated, and other people usually want to vomit. So if you suspect this, in most cases, what they do is go to you tend to sit down with a health worker, and usually what is given first is the nasogastric tube. This will help in decompressing the stomach and also relieve the pressure. Okay. Yes, and also we are looking at critically ill patients. If a patient is critically ill, then we can indicate the enteral nutrition. Right. So what are the contraindications for the enteral nutrition? Okay. Uh, Contraindications is when not to give, or what would be the problems when you give. Okay. Yeah. So under complete bowel obstruction. Okay. When now all the normal flow of the intestinal contents is obstructed totally, now can't indicate enteral feeding. Okay. Yeah, because enteral feeding would worsen the obstruction. Remember, now we are also adding another tube into the intestines that are already obstructed. Okay. Also, severe and uncontrolled vomiting. This can cause aspiration risk. And aspiration, really, here we are looking at the contents going into the respiratory system. Okay. Yeah. If a person is over vomiting, then we won't prescribe this, because sometimes people have these swallowing difficulties. Okay. So instead of the fluids that we wanted to direct into the digestive system, now because we have a tube into the area that is already complicated, okay, we are putting feeds through the nose of the individual using that tube. So if a person is vomiting a lot, we understand. That's why I told you when we are doing these interventions in the hospital or in the clinic or in the health center, don't do it alone. Okay, don't risk someone's life because you want to show off, because you want everyone to know that you're putting in a nasogastric tube. Don't try to show off on people's lives. If you can't put it in well, then talk to a physician to help you. Okay, if you can, please refer. I really like you rather go to a place that is having a lot of referrals than having a lot of deaths, because people are being careless with other people's lives. Okay. So in cases of severe uncontrolled vomiting, please, let's not give enteral nutrition. We have other forms of delivering nutrients, as we will see later on in this segment. Okay. Also, severe gastrointestinal bleeding. Remember, like you will see, there is a sharp end to the tube. So if we are putting in the tube and there is gastrointestinal bleeding, this tube might scratch the linings of the intestines or the linings of the gut. Okay, and if this happens, there will be a severe bleeding which will worsen. And you know, when bleeding happens, what happens? This attracts all kinds of infections because there are a lot of nutrients in the blood. Okay, and like I told you, if you feel things are not going well, please consult. Okay, don't die alone. This is not a time for you to show off when you're treating people. Okay, so in cases where we have systemic bowel disease, this one is where there is reduced blood supply to the intestines. Okay, so this reduced blood flow to the intestine compromises the nutrient absorption. Remember, we are trying as much as possible to deliver these nutrients to those various parts for easier absorption. But now, if the blood that is required, we all know that the blood is the one responsible for transporting of nutrients across the body to places where they are needed, and some for storage. Okay. Yeah. So if the blood is not flowing around those places, then there is no reason why we are trying to put the foods there that are not going to be absorbed at the end of the day. All right. Untreated peritonitis. Here we are looking at inflammation of the abdominal cavity, and we are saying this can be dangerous. So these are the way. These are the issues that could come in handy if you indicate enteral nutrition, and things could really go bad. Okay. Okay, some could be due to enteral nutrition, and some could be problems that you could face or where not to give the enteral nutrition in case you get a case like that. Okay, so what are the types of enteral nutrition or enteral tube feeding? Uh, Sorry, what are the types of enteral nutrition? Here we have the enteral tube feeding. We also look at the parenteral, and also there is also the oral nutritional supplements, or you could call ONS. These, in most cases, there is a lot of ongoing information about them. People have been very skeptical about these supplements because there is a very little knowledge about their long-term impact. Okay, that is one. There is also what would we call it? People suffer from addiction. Okay, every time people don't want to put in the work. We understand if we are giving etc. But if we are just prescribing supplements, people tend to be laid back. And at the end of the day, we don't know what the long-term impact of these supplements will do. You know, there are always adverse effects, as you will see when we go deeper in the course. Okay, so the enteral tube feeding, like I told you, is used for patients who cannot safely or adequately swallow. And also, what are the routes? The routes we are looking at the nasogastric tube, that is short term. We are saying this is through the nose to the stomach. And then gastrostomy, here we are looking at the V tube. This is long term, and this is through the abdomen to the stomach. Then others, we have the duodenostomy. Then also we have the nasojejunal tube. The interesting bit about these gastrostomy, when we talk of ostomies, anostomy is a whole, okay? Anostomy is a whole on the digestive system. So I think if people have been to places where they rear animals, in most cases cows, this is where this is mostly done for cows that cannot eat. What they do is should I call it puncturing? We cut a hole, okay? And it's through that hole that we can deliver the nutrients to that digestive system, okay? Yeah. So here, this is a surgical procedure normally, okay? So we create that opening. In most cases, this opening is called a stoma, okay? Yeah. So sometimes people do it to divert the flow of urine and feces, etc. But here, really, we are looking at putting that hole for you so that we can put the nutrients into the digestive system. I hope we are clear. That is with the ostomies, okay? And we don't really encourage this, but at extreme conditions, when it is life-saving, that's when, because remember, when we make a hole on the digestive system, we are making the hole up to the outside part of the body, okay? So we open, we put the nutrients, then we close. That means we can't put anything through the nose, we can't put anything through the what? Through the mouth. So these things go in order. If oral fails, then let's go to the nose. If the nose fails, then let's do the ostomies. If the ostomies fail, then let's go and do the end part, which will be the parenteral nutrition. All right. So what are the indicators for enteral tube feeding? Like I told you, there are different tubes, and these different tubes, I believe we can get them by name because it is from the beginning part to where we want the nutrients to be disposed or to be directed. Here we are looking at the unconscious patients, we are looking at anorexic patients, and also we are looking at people who have upper gastrointestinal obstructions, like we had looked at them. Okay, and friends, for anorexia, here we have the anorexia. There are, I think, two forms of anorexia. We have anorexia nervosa and anorexia bulimia. These are just eating disorders. Okay, we rarely do we have. I know even in Africa we have them, but really these are white things. These are things for whites, where people don't want to gain weight and still they try as much as possible to uh, find ways of eliminating food intake. Okay, yeah, because people really want to stay in shape and also don't want that distorted body image. People will start starving themselves. Some people start vomiting, and this leads to some physical consequences whereby electrolyte imbalance could happen, hormonal disruptions. That is where you need to come up and tell people if you start losing weight, you will find yourself that you're not even getting the periods that you're supposed to get at the end of the month. etc. That will be a story for another day. Okay, so what are the types of enteral tube feeding? All the enteral feeding tubes. One, we looked at the nasogastric tube, and we are saying this is a thin, flexible tube that is inserted through the nose into the stomach. And this is usually used for short term. Okay, feeding should be less than 2 weeks. That's according to me. People can talk of 4 weeks, which could be a month, but me, I'm looking at 2 weeks because we are looking at what easiest way can we bring back the patient to normal feeding. Okay, in what way can we bring back this patient to oral feeding? We will see that unless we fail completely is when we advance in the steps of delivering these nutrients into the body. Okay, so they are saying it is easy to insert and less invasive like other tubes. Usually we can say it is easy to insert for the trained professionals. Okay, don't go playing on people's lives trying to put tubes through their nostrils or through their noses because you want to deliver feeds because you feel you went through a nutrition class. So what are the cons? This can be very uncomfortable for people who have been on wards. Ideally, usually it is the pediatric ward. Okay, the children with these tubes on their noses are always very irritable. Okay, even if you touch the child, you just want to play with them. They're very irritable. And for the parents, we as healthcare professionals, we need to always take concern. Let's not be very imposing. For an nasogastric tube to be inserted into someone's child, even if it's your child, at one point you will be feeling, remember, the nose is supposed to be only taking in air. However, now okay, people have started putting different types of smoke in their nostrils. I don't know how they discovered that, but I'm not so sure. But the nose is supposed to be for only and only breathing, okay, taking in air. But now imagine we are putting in a tube, a plastic, okay. So it is very uncomfortable and it is also very irritating. Like I told you also the risk of aspiration. Remember, we have a lot of pathways here, okay. We have the air pathway and also we have your digestive system, the tract, okay, yeah. So in any case, there could be chances, okay, of you putting the tube in the wrong place and it will cause aspiration. Right, and also maybe to tell you one thing about is this thing could also bring problems if it is given to people who can't wash it. Okay, we believe that every after is it? I beg to be corrected. Is it every after two to 3 days? I think it's every after 2 days that this tube should be replaced. Okay, we are not saying that now you're taking off a person this enteral feeding program. But what you're doing is you're replacing that tube with a new tube because the feeds you're putting in are now clogging the tube. That is one, they could clog the tube. But they could also bring in bacteria. Imagine bacteria coming into the tube that you're putting through someone's body. Okay, yeah. And also the other type of enteral feeding, we have the gastrostomy. Here we are looking at the tube being inserted directly into the stomach through the abdominal wall, like I told you. Here we are saying usually it's a long term. Okay, this is more than 4 weeks. We are having an opening of new, but still, if we are able to, maybe the problem was bowel obstruction. If surgically people are able to realign your to remove the obstruction, really we go back to one of the basics. Here we can go back to the NGT, or we can go back to oral feeding at the end of the day. So it is more comfortable than nasogastric tubes, and there is less risk of aspiration since we are putting the feeds directly into your stomach. We have made an opening here on your stomach, okay, not through the nose but on your stomach, and that's where we are putting the feeds. So what are the cons? Okay, the challenges is it requires a surgical procedure to take place, okay, and also carries a small risk of infection. You're going to be having an opening on you. Anything can happen, you know. Of rare cases that we are supposed to be opening the body, someone had stated, one doctor stated that we are not supposed to be opening the body. It is on very, very, very rare occasions that we are supposed to be opening the body. That is why wherever God wanted for us to have an opening, the opening is there. Okay, that is why sometimes we discourage women from cesarean section. Okay, but you realize right now there are high-end women who don't want to push children anymore. But God created that opening for you to push the child. But the woman, no, me, I want C-section. And the doctors want to make money at the end of the day. They will choose to operate you, but at what cost? Okay, yeah. All right. What I'm trying to say is having a surgical procedure should be when all things have failed. Please and please, if you believe for you have a surgeon who wants to make money, always, and these days the doctor is talking about because I think a C-section is 1 million Uganda shillings. I don't know how much it is that side. 1 million Uganda shillings. If someone can do 4 C-sections in those high-end hospitals, 4 C-sections in a week, that is 4 million per week. Okay, so 4 million Uganda shillings per week. That is around 1,200 US dollars around there. So 102 to 1,200 US dollars a week, then they will top up with their salaries or even more, okay, depending. So they actually then brag about it. Whenever you try to push a little and they tell you stop, then they will choose to do the surgical operation on you. That is a story for another day. For the other thing is the duodenostomy. Here we are saying that tube is inserted directly into the duodenum, the middle part of the small intestine. And this is used for people who cannot tolerate feeding into the stomach. Okay, there are people with the stomachs that are upset. Then also I heard of an issue of ulcers. Okay, people with ulcers and also they have the obstructions, then they can't take anything orally and they're feeling very uncomfortable with the nasogastric tubes. This can be done. Okay, so this bypasses the stomach. It's not a gastrostomy, which can we are saying this can be helpful for people with gastroparalysis that have a slow stomach emptying. And also, what we are saying, this also requires a surgical procedure to take place and carries a small risk of infection. So other enteral feeding tubes, we have the nosoduodenal from the nose to the duodenum. Don't confuse it with the duodenostomy. Okay, so this is from the nose to the duodenum. It is similar to the NGT, like I told you. Then we have the esophagostomy. The esophagostomy tube. This I think you have seen. In most cases, you have those people who have a hole here at the throat. Okay. Yeah, and people are feeding them through that tube. Then we have the percutaneous endoscopy gastrostomy. Here, the gastric tube is placed using the endoscope or a thin flexible tube with a camera. This is in cases where there is a lot of challenges in the gut. You don't know where to put, things are all mixed up, and as if this was done with some children somewhere on a study article I was reading. Okay, so let's shift and look at the nutritional supplements for patients who struggle to meet these nutrient needs through diet alone. Then we prescribe these nutrient supplements. Okay, yeah, But we don't want people to rely entirely on supplements. We want you to be able to go back to eating things normally. Okay? Yeah. So what are the indications in malnutrition? We give these supplements. For individuals with risk of insufficient intake, we give these supplements. For example, if we give folic acid supplements to pregnant women because we want to prevent neurotube defects in the infant or in the child that will produce at later on, because what they have is insufficient and they can't also meet it through intake. But also individuals with normal swallowing still can give these oral nutrient supplements because they can able take them in. And also for individuals with normal functioning gastrointestinal tract for proper absorption and utilization of these nutrients. So the complete oral nutrition supplements, these provide all the essential macro and micronutrients in balanced proportions, okay? And they can be used in sources as a sources for nutrition for individuals unable to meet their dietary needs through diet alone. Realize that food is not there. In most cases, this happens in those camps, okay? Yeah, where the person, you don't know when the person will take their next meal. The food is very limited. So these are given. Okay. Yeah. For example, if they have a lot of children at home, you can give the food but also give these supplements at the end of the day. Then we have the modified oral nutrient supplements, and these are designed for specific medical conditions or dietary restrictions. And we are saying these may have lower protein content, such as for those people suffering with the kidney disease. Then also we are saying that we are saying reduce lactose for those people with lactose intolerance, and you all remember lactose is the carbohydrate found in milk. Also increase fiber for the digestive issues. You know how that stuff, that roughage is essential for digestion to take place, and also specific fatty acid profiles for metabolic disorders. And the examples are there. You can read about them in your free time. Then the single nutrient oral nutrient supplements. Here, these ones provide concentrated source for specific nutrients, like for the protein alone, or for the fat alone, or for the carbohydrate alone. These are used for specific deficiencies. Okay, if you're deficient in a particular nutrient and that nutrient of interest, we will indicate these supplements for you, or you will indicate these supplements for that patient, etc. For people who need to increase their calorie intake without additional volume, okay, you don't want to eat a lot, but then you just want to increase your calorie intake. So that is why we are saying traditional nutritionists always discourage this. We want to have the organic foods deliver the nutrients to you. We don't want to deliver nutrients to you that are synthetic, okay? Because we don't know for how long you're going to use them. People have actually used supplements in bodybuilding. I know you have come across people who have been disqualified in most of those. I think they call them mania something, where people are doing those bodybuilding activities or competitions. So for people who are using supplements, they are not natural bodybuilders. So what happens is they disqualify them. So what are the types of the enteral feeds? Okay, we've seen the various tubes and where the nutrients are delivered. Now we are looking at what are the types of feeds that you're going to be putting into those tubes. Okay, so we have the general, which would be the polymeric. Here we are having the standard formulas for general, for normal digestion. Okay, everything is put in its respectable amounts: the fats, the carbohydrate, the protein, etc. Now they are no longer carbohydrates. They could be amino acids. They could be fluids, etc. that are being put in. Then we have the elemental or the semi-elemental for the impaired digestion. These are easier to absorb. And also we have those that are disease specific. Okay, these are tailored formulas to the specific conditions. You will read about these and they're very interesting. For people who have been I think for most of the adults have at least got IV treatment. When we look at IV treatment, we have dextrose. Dextrose, you know what, it depends on people with some knowledge in the medical background. Some people are given dextrose 10, some people are given, but now you realize that is a carbohydrate that is being indicated into your bloodstream now. It's not, we realize that we don't want we want you to have energy instantly. Okay? Yeah. But now we don't want to put the nutrients through the digestive system. It's going to take long, yet we want to save lives. So what we do is we will put that IV or the intravenous fluids into your system so that the body can pick up quickly. Okay, specialized feeds, we have the renal feeds. When we talk of renal, we are looking at the kidney. Pulmonary feeds, we are looking at the lungs. Hepatic, we are looking at the liver. Then the diabetic, we are looking at people with challenges of diabetes and also the immunonutrition. For the immunocompromised individuals, for renal feeds, we are saying these are limited in sodium, potassium and phosphorus to manage the electrolyte balance, and also this is in the chronic kidney disease. Okay, so varied protein content, here we are looking at the lower protein content for the early chronic kidney disease and the higher protein for the advanced stages and also dialysis patients. Okay, then for energy dense for managing the fluid restriction of the chronic kidney disease. And also we are saying their uses why we are giving these renal feeds is to manage the electrolyte balance. Okay, this should be to manage the electrolyte imbalance and also the nutritional needs of patients with this kidney disease and also for people who are on dialysis, and also to help and reduce on the workload of the kidneys and the nephrons by limiting the excess protein and also the electrolytes. For the pulmonary feeds here, we are looking at higher fat content compared to the standard feeds. These reduce carbon dioxide production during metabolism, easing breathing in patients with respiratory issues. So this also would this may also contain antioxidants, the omega-3 fatty acids. I don't know whether you covered all this in. There must be something, maybe it should be dietetics 1, something like that, where you look at the various nutrients and their importances. Okay, so here we are looking at the antioxidants and omega-3 fatty acids for their potential anti-inflammatory effects. Okay, so this supports nutritional needs in patients with chronic obstructive pulmonary disease and other respiratory conditions. The take home is to reduce the carbon production and also potentially improving the breathing and also tolerance. We are looking at hepatic feeds, like I told you. These are low in aromatic amino acids such as phenylalanine and also the tyrosine, which can be difficult for the liver to process. We all know that protein metabolism takes place in the liver and also carbohydrate metabolism. Yeah, sure. So we are saying that high in branched chain amino acids to promote muscle protein synthesis and also to reduce muscle breakdown. However, really we would only take away the major important part of its aim to prevent muscle wasting and also improve nutritional status. However, this is also enriched with antioxidants and vitamins to support the liver function. So for the diabetic feeds, we are saying these ones are low in carbohydrate content with specific types of carbohydrates, slow or low digesting fibers to prevent to help manage blood sugar levels. I think for people with a medical background, you know that we intend to use the low glycemic index. Okay. Foods with low glycemic index that release glucose slowly into the bloodstream we don't want to shock the system with a lot of glucose for the diabetic clients. And we are saying this may contain dead healthy fats and antioxidants to support cardiovascular health, because these they call them metabolic, is it metabolic syndrome, all those diseases that happen due to differences and challenges in metabolism. Okay, so its uses, we are looking at it being able to support the nutritional needs and diabetes management in patients with type 1 and type 2 diabetes. I think we all understand type 1 and type 2 diabetes. If not, let's go back and read. Also, our aim is to improve the glycemic control, like I told you, and also to reduce the risk of complications. Surely, for the immunonutrition feeds, we are looking at being able to contain the specific nutrients believed to support the immune system, such as the glutamine, which is an amino acid important for gut health. When we talk of gut, we are talking of the digestive tract and also the immune function. Arginine, which is an amino acid with potential immune enhancing effects. The omega-3 fatty acids that have inflammatory properties. The nucleotides, which are the building blocks for the deoxyribonucleic acid and the ribose nucleic acid, DNA and RNA respectively, which are crucial for the immune cell function, and also the antioxidants. These protect the cells from damage and also support the immune function. Friends, we are running out of time, but I think I have a number of slides that we need to go through very rapidly. There is some, I think we have around 7 slides. So bear with me for the 7 slides so that we can finish them, then proceed, so that I can wish you a good weekend. So how do we choose the right enteral feeding tube, and also we here in choosing the right enteral feeding tube? So we first of all, what we consider is we predict the duration of support. You can look at a condition of an individual and then predict that in 2 weeks this person will be well, or in 2 weeks this person will have improved. So there is no mark who is going to be well in 2 weeks. What is the use? Okay, but if we believe that this person might be unwell for a number of months, then we can put an ostomy on them. Risk of aspiration or tube misplacement, if someone can still eat orally, if you can still give these supplements orally, why are you opting to put an nasogastric tube? Prediction and absorption, those we've seen. Surgical plans, we've seen. If we don't have a surgeon on ward, please, the nutritionist, don't puncture someone. Then texture and volume of the feed that is required is also key. Administration methods and devices for enteral, we are looking at the nasogastric and also the nasoeccentric, then the gastrostomies, then the duodenostomy tubes, that is for enteral. Then the parenteral, we are looking at putting the nutrients into the central, the central and the peripheral nervous, it's not nervous, sorry, the venous system. We can't put nutrients in the nervous system. Apologies. Enteral, parenteral, we have, like I have told most of you, those are the IV fluids that are put onto us. We call them drips in our layman's language. We realize that in most cases, even when we have children on ward, when we have failed to locate any veins on them, where do they put the tube, or where do they put the IV fluids? They put them on the head. Okay, they look for the major veins on the body. There is the through that. So fiber in enteroformula, that bacteria is also essential in the digestion, also softening of stool and aiding lectin, psyllium, guaiacum, and inulin. So the recommendation is to include these amounts, the 10 to 25 grams per day for gut health and regularity. Insoluble fiber, we have said this does not dissolve in water, but it adds to the bulk of stool, promoting bowel movement. Remember, we had some issues to do with bowel obstruction earlier on that were discussed. The indications for this enteral feeding. So what are the rules? We are looking at preventing constipation and promotes bowel regularity, increase satiety, reduce bran, and also this could be cautiously indicated in the enteral formulas as it can weaken and impact the flow. So monitoring feeding patients on enteral nutrition, we are looking at you tracking that person's weight, then also monitoring the fluid balance because you're putting in a lot of locked in, okay, and end up giving the person more fluids than they require. We will look at also the blood sugar and also the bowel function. We will read further actions of enteral feeding. One, we talked of gastric stomach and the increased aspiration risk and how we communicate. We are putting in fluids. Remember, the body is not getting anything here and there. So how do we do this? We adjust the formula's composition, okay, and also manage medications. Like I told you, can also look at putting in the fiber. Constipation here is infrequent and hard stools. We are also looking at increasing the fiber in the formula to consider stools softening. Tube blockage, like I told you, at the end of the tubes, these tubes could get blocked. To flush the tube regularly. And also we could replace the tube. Okay, the replacing the tube means you have to go through the whole process of putting the tube again. But for you, in turn of injuring someone's life. Stoma is the opening. The stoma site issues such as the infection, leakage, or the irritation around the feeding insertion site. So here we need to make sure that we clean these areas properly, care and also monitor for the signs of infection, the pus that could be coming, etc. The refeeding syndrome, we are looking at the rapid shift in the electrolytes, okay, pump, etc. I think we will interest with that ourselves with that at one point later on in our engagements, especially potassium and phosphorus upon initiating feeding of the severely malnourished patients, leading to potentially fatal complications, ascites, and all those other things. Risks such as heart arrhythmias and also muscle weakness, respiratory failures, and comas could result if you make mistakes while in this enteral feeding, and this feeding syndrome is very common to happen. Prevention: start feeding slowly, gradually increasing the calories, and also closely monitoring the electrolytes. So, really, enteral feeding techniques and administration routes. We have looked at for bolus feeding. We are looking at administering the large volume of formula at regular intervals. In continuous feeding, this is slow and continuous administration. This is more enteral feeding. Then also the administration notes really depend on the patient's condition and their nutrition requirement. So, friends, I believe I understand this is a lot that we'll cover today. But if we go back on these slides as we are doing some bit of research and reading here and there, because class can never provide you with all the information required about these, because we always have only 1 hour of engagement. So ideally, and we